Okay, so first of all, welcome all from different parts of the world, and thank you for your interest in hepatitis B and especially in the ECHO hepatitis B project. So in the last module, just to recap, we talked about the epidemiology where hepatitis B is prevalent, and we also talked about several patient barriers and clinician barriers and system-based barriers. So today's module is all about hepatitis B serologies and interpretation. Okay, so again, from the polling notes and the results, I see that most of you know at least how to always diagnose hepatitis B based on serologies, and some of you don't. And again, during the whole presentation, what I would strongly recommend is if you have any cases that you saw with a patient with hepatitis B, please share them to the rest of the group, so it'll be a good educational learning objective for everybody else. So today we're going to talk about serology, and as you saw in the video of Yuan Li, she's a 28-year-old woman. She was born in the United States, right? So obviously you think United States is a low endemic region for hepatitis B, but she was actually born to parents who emigrated from Taiwan. So Taiwan is a region that has high prevalence of hepatitis B. So one of the important CDC recommendations is if you were born in an area with high prevalence, or if you're born to parents from an area of high prevalence, these individuals should be screened for hepatitis B. So when she meets with her primary care physician and she talks about family planning, again, we actually identified that that's a perfect context to screen for hepatitis B, because we can not only identify her with hepatitis B if she has, we can also stop the transmission from mother to child, right? So in this example, when we think about ordering the test for hepatitis B, last module, we actually heard from one of our audience members that they also check for hepatitis B envelope antigen and envelope antibody, okay? So this is to kind of give a contrast that those tests are not needed to screen for hepatitis B. There are three important tests which are really necessary when you're screening a patient. One of them is hepatitis B surface antigen. Now, surface antigen is the marker of active infection, okay? And a patient who has surface antigen positivity for more than 6 months, that is enough to diagnose a patient with chronic hepatitis B, okay? We don't need hepatitis B viral load. We don't need anything else to diagnose chronic hepatitis B. Surface antigen positivity for 6 months is indicative of that condition. Now, we also check for hepatitis B surface antibody. Now, sometimes in your labs, you can be seeing the result as anti-HBs antigen, which basically means antibody to hepatitis B surface antigen. So this particular test is a marker of immunity to hepatitis B. The third test is presence of hepatitis B core antibody. We cannot test hepatitis B core antigen, but we can test core antibody. So if there is presence of hepatitis B core antibody, that basically tells us that the patient at some point in the patient's life has been exposed to hepatitis B. There is a small percentage that this could be a false positive result. Okay, and we're going to talk more about these serologies in the next few slides. Now, when you're suspecting that a patient has acquired acute hepatitis B, an additional test that we typically recommend is the presence of IgM. So when your IgM anti-hepatitis B core antigen. So in a normal case, when you order for hepatitis B core antibody, what you're going to get is the IgG. But in an acute case, when you're suspecting that the patient probably is a post-needle exposure, or the patient has acquired it from a sexually transmitted infection or IV drug use, then is the time when you actually check for IgM. Now, if step one, if the surface antigen is positive, that is the only time when you actually check for these three additional tests. One of them is hepatitis B envelope antigen. Now this is, if you look in the medical textbooks, this is a marker of high viral load. So envelope antigen is basically, it tells us that the hepatitis B is a wild type virus, and wild type virus is very contagious, and typically the viral load in E antigen positive patients is very high, typically more than 5 logs. Then there is another test called the hepatitis B envelope antibody, or this is the antibody to the E antigen. Now, this can be positive, and the patient can still have chronic hepatitis B. Okay? This does not mean that the patient is immune. So this can happen in patients who have not the wild type virus. So there have been mutations which occur due to environmental pressures, due to vaccine pressure, due to treatment pressures. So in a community, like for example, Taiwan, in our patient, the patient can have an E antigen negative chronic hepatitis B throughout her life. So again, we check for E antigen and E antibody only if surface antigen is positive. The two typical mutations that are positive in E antigen negative hepatitis B is the pre-core and the basal core promoter mutations. The significance of this is if you have E antigen negative disease, you need to think about treating these patients even when they have very low viral loads. So the viral loads can be in more than 2,000, and still the virus can cause significant complications in their lifetime. So again, your threshold for treating the hepatitis B in this particular situation, in an E antigen negative situation, is a lower threshold of virus. Then obviously we're going to check for hepatitis B DNA, because DNA, this is a marker of active viral multiplication. So if, again, the patient is actively replicating, we are going to see positive viral load. This also helps us in identifying how the patient is doing on treatment. Typically, we do have several treatment agents that are available, and they're very effective. So on treatment, you should not see any viral replication. So if a patient has an undetectable virus, and again, you start seeing that the viral load is positive, you can start thinking that this patient is either non-compliant, or depending on the medications you chose, the patient may have gotten resistance to the treatment you put the patient on. So again, continuing with the hepatitis B serologies, these are different scenarios of the same viral serologies that we have talked before. If the patient has all screening tests that are negative, meaning surface antigen is negative, hepatitis B core antibody is negative, and hepatitis B surface antibody is negative. Now, this is an individual who is susceptible for hepatitis B. So if the patient comes from a highly endemic area of the world, or if the patient is at risk to develop hepatitis B, either because you're seeing this patient with a sexually transmitted illness, or if the patient has multiple sexual partners, or patient is MSM, or the patient has IV drug use, this is a patient who we as providers can do a better job in vaccinating these individuals, and we can prevent them from getting hepatitis B. And again, all the medical practitioners, all the healthcare providers, nurses, at least in the United States, and I'm hoping in New Zealand as well, they all get vaccinated if you're signing up for a job in the hospital. I want to hear more about the clinical practices in Nigeria, though. Is hepatitis B vaccination a common recommendation or not in healthcare workers? So the next scenario we're going to talk about is hepatitis B surface antigen is negative, but the patient does have hepatitis B core antibody, and the patient also has hepatitis B surface antibody that is positive. So this situation typically is signifies that the patient was immune to a prior infection with hepatitis B. The presence of core antibody, like I said, it basically is a marker that the patient was at some point infected and he got the hepatitis B virus. This kind of scenario typically happens if you acquire hepatitis B in the adulthood. So again, your immunity is competent. You can clear the infection. You can make the hepatitis B DNA undetectable. And at the same time, you actually develop surface antibody, which is going to keep you immune for the rest of your life. The third scenario is hepatitis B surface antigen is negative, core antibody is negative, and you are seeing that the only test positive is hepatitis B surface antibody. Now this, you have to commend yourselves or your peers, because this is a patient who is immune to hepatitis B vaccination. So if you actually take scenario or square one or row one, you identify a susceptible individual, you vaccinate them, you're going to see that the third box will be the case. Okay, you're going to see that response, that they mounted an antibody to the vaccination. So far, any questions? Kate, are you seeing any questions on the poll?
I've got no raised hands or chat right now, but again, just want to remind anybody, if you do have questions, feel free to put them in the chat in general or direct them to me, and I'll make sure Dr. Bhamidimarri receives them.
Yes. And again, I would urge that don't think that this is a didactic presentation. You don't have to wait until the end of the topic or at the end of the conference. You can actually raise hands and you can ask questions. Let's keep all of this as interactive as possible. Okay. So now, moving along with the serology interpretation, now you're seeing that hepatitis B surface antigen is positive. That obviously means that the patient has hepatitis B. The core antibody is positive. IgM is also positive. So when you're testing for core antibody, typically it's IgG and IgM. And if IgM is also positive, this is a case where the patient is acutely infected. Okay. So the next box, again, when you're seeing hepatitis B surface antigen is positive, core antibody is positive, IgM is negative, and surface antibody is negative, this is a patient who is chronically infected. So if you want to take one message from the slide, surface antigen positive for more than 6 months equals chronic hepatitis B. Okay, so you don't need anything else. Now, the last scenario, which is also quite common in clinical practice, is you have all the tests that are negative except hepatitis B core antibody. Now, if that is the case, there are 4 possibilities. The top 2 are the most common, okay, which basically signifies that the patient had a chronic infection sometime in the past and the patient did not mount a surface antibody. So he's not yet immune, but it typically represents that the patient had a prior infection. In about 10% or so cases, this could mean that the patient has a false positive core antibody. This typically can happen in patients who have autoimmune disorders, or if the patient recently got a vaccination or the patient had a viral illness. You can see that there is a transient development of hepatitis B core antibody as a result of their immune status. So how do you know if this is a false positive or not? Well, you can make a guess to get a good history. And if you're not certain that the patient ever gotten or acquired hepatitis B in their life, you can actually try and give them a vaccine series and expect if they can mount hepatitis B surface antibody. The last 2 are basically for academic purposes. So this individual can be having a core antibody if they have a very low level of replication. So there is a condition called occult hepatitis B, where typically most of the serologies are negative, especially hepatitis B surface antigen is negative. But when you test, there can be core antibody that is positive. And if you test for DNA in the serum, or if you do a liver biopsy because you're suspecting cirrhosis or advanced fibrosis, you can actually find DNA on the biopsy. So again, an occult hepatitis B infection is a possibility, but it is not a very frequent scenario. And then finally, if the patient recently acquired hepatitis B and is clearing the hepatitis B, Now that is a situation where the core antibody is on its way of getting disappeared, and you still haven't gotten the surface antibody yet, but this patient is going to recover soon. So that's the fourth scenario. I hope I'm clear with the serology interpretations thus far. And again, like I said, I urge you all to ask questions if you're still unclear about this. So when we look for lab tests for chronic hepatitis B, like I said, we look for markers of replication. So surface antigen tells us that the patient has hepatitis B. Envelope antigen and envelope antibody will tell us whether the patient has wild type or a mutant variety of hepatitis B. And the DNA is definitely one of the tests that tells us about the amount of replication that the hepatitis B has. Now, once you know about the hepatitis B from a viral standpoint, we need to know how the patient's liver is doing. So typically we look at the biochemical parameters. Every one of us know how to do it. This is looking at alanine aminotransferase. This is an enzyme very specific for liver injury. Then in any patient who has chronic hepatitis B, we also need to at least identify where their liver fibrosis stands. So typically a baseline fibrosis will tell us whether this patient needs to be worked up or for transplant, or if the patient is at a much higher risk for liver cancer, or if the patient needs treatment right away. So again, a fibrosis marker, this can be done easily with the use of non-invasive techniques. We use liver elastography. This is either through FibroScan, or there are several biomarkers. We can use FibroSure, the APRI test. All of these can be easily done non-invasively to assess liver fibrosis. We do use liver biopsy in selected cases, especially in individuals who have hepatitis B, and you're suspecting that there are concomitant risk factors like alcohol, like iron overload, fatty liver, and other markers of liver inflammation. So moving along, for hepatitis B natural history, this is kind of like a historic way of looking at the clinical phases of hepatitis B. So every patient, once the individual gets infected with hepatitis B, typically they can be e antigen positive. This is infection with the wild type. And throughout their course, as the e antigen becomes, as the e antigen disappears, they can develop into a e antigen negative chronic hepatitis B. But again, that being said, there is also a condition where chronic hepatitis B can develop from e antigen negative patients. So these individuals will be positive for e antibody throughout their life. Okay. So in the beginning, when they get infected, their liver enzymes can be normal, but they can have very high levels of hepatitis B DNA. This phase is typically called an immune tolerant phase, meaning the immunity is tolerating a high viral load. So you're not seeing liver inflammation, you're not seeing elevated liver enzymes, but when you follow these patients throughout with periodic liver tests, and again, if you're thinking that the patient has significant fibrosis, it's better to do liver tests more frequent. A general recommendation is you do the liver test every 6 months. That is a minimum requirement. But if you're suspecting that the patient has this fluctuating liver enzymes, fluctuating viral DNA, you can actually test them every 3 months. And if you test them more, you can actually identify several data points. And this is actually what happens. So ALT can be fluctuating, DNA can be fluctuating. Okay. So if you do less number of tests, you can basically pick the ALT and DNA at the troughs, and you may think that the patient doesn't have any active inflammation. But in fact, these dotted lines will tell you that throughout the course, the patient can have a fluctuant variations in their ALT and DNA. Now, if you see that the ALT is elevated and the DNA is kind of getting subsided, this is a patient where the patient's own immunity is trying to control the virus. Okay, so this is a protective mechanism where the immunity is trying to clear the hepatitis B. So this phase is called the immune clearance phase. And if the immunity does a good job in controlling the hepatitis B DNA, the next phase is the ALT remains low and the DNA remains low. So this is an inactive carrier state. And again, as one grows older, or if one develops a need for immunosuppressive medications, may that be steroids, may that be biologic agents which are increasingly being used, may that be chemotherapy or anti-rejection medications after transplant, this virus can basically reactivate because the DNA is present, it's at a low level, but when the immunity is suppressed, when that control is gone, the virus basically reactivates and causes a flare.
Hi, Ram.
Yeah.
We actually do have one question from Claudia. She's having a little audio issue, but she sent it to me directly.
Okay.
She said, is there a role for hepatitis B surface antigen quantitative at the time of screening?
So that is a great question. Hepatitis B surface antigen titers are still being investigational. We are using it as a marker, as a biomarker to see if hepatitis B is getting cleared from the host liver cells, but this hasn't been a standard of practice yet. But it does provide a lot of information. This is at least based on the investigational research that we're doing. Surface antigen clearance basically tells us how the activity of hepatitis B is within the liver. Okay, but we don't have to do it. That's the short answer. So looking at the old terminology and the updated terminology, you'll see that we are trying to shy away from using the words immune tolerant, immune clearance, inactive carrier, or reactivation. Although all these terminologies do make sense, the new terminology that we're recommended to use is presence of hepatitis or the presence of, is someone talking?
We do actually, we do have one raised hand, so I'll unmute Mubin here. Mubin, can you hear us?
Yeah, I didn't mean to interrupt you, Dr. Bhamidimarri. You mentioned about ALT, so we still follow the threshold for the hepatitis B, like 25 and 35, right?
Or hepatitis B, that's so I'm glad you asked the question. So the threshold for knowing whether there is liver inflammation in hepatitis B context is males, anything over 30 is considered abnormal, and women, anything over 19 is considered abnormal.
Okay.
Okay. So yeah, great point. Okay. So as we're talking about the new terminology basically talks about the presence of hepatitis or the presence of infection. Okay. So every time there is a elevated ALT, we're going to call it hepatitis. And if the ALT is normal, we are going to name that as a chronic infection stage and not as a chronic hepatitis. And again, during the whole natural history, as the hepatitis progresses, there will be the inflammation basically results in significant laydown of collagen, which results in fibrosis, cirrhosis, and we know that hepatitis B can cause liver cancer even without the presence of cirrhosis. So, anyone has questions at the moment?
Yes, it looks like Karen has a question.
Okay.
Karen, you should be unmuted now if you wouldn't mind asking your question.
In following a hepatitis B patient who say is immune tolerant or doing well, do you just check the ALTs and HB the DNA levels, or you do all the serologies every 3 to 6 months?
Okay, this is a patient who you're treating, or this is irrespective?
Maybe they're immune tolerant. You just
Okay,
they're
so
doing
immune
well.
tolerant, not on treatment. So again,
Yeah.
so the first step is, once you figure out that the patient has chronic hepatitis B, right? So surface antigen is positive. You need to identify to put them in either buckets, which is e antigen negative or e antigen positive. You need to have a general idea whether this is a wild type virus or this is a patient with mutant virus. So with wild type virus, the threshold is to treat. Threshold to start treatment is more than 20,000 copies. Whereas the threshold with hepatitis E antigen negative is 2,000. Okay? So
Yes.
if the patient has E antigen positive disease, you should basically be checking E antigen, E antibody, DNA, surface antigen, and surface antibody. So you need to check all those along with ALT every 6 months.
Okay.
Okay, because the first or the more frequent thing to happen in these individuals is E antigen seroconversion. Okay, so if you go back to, I'm sharing the slide with you here. So as E antigen basically gets disappeared and these patients develop E antibody, most patients can actually have control of the DNA. So this is called E antigen seroconversion. So in those kind of cases, you basically follow them at least for 6 months to 2 years. And if the hepatitis B is undetectable, and if they're on treatment, treatment can be stopped. Okay. Now, if they're E antigen negative, there is no point in following E antigen and E antibody. So you're actually going to follow 2 tests less every 6 months. So you're basically doing surface antigen, surface antibody, DNA, along with the liver tests. Okay. And the other thing also, because hepatitis B causes cancer, the other recommended serology or the other recommended blood test is an alpha-fetoprotein. So again, we need to screen for hepatocellular carcinoma. Now, the recommendation is don't use blood tests alone. You need to do a scan. Typically, we recommend a liver ultrasound every 6 months. So again, you need to keep in mind whether you're treating or not treating, all hepatitis B patients should be screened for HCC. And again, the recommendation is with a scan. We also do a blood test. It's called alpha-fetoprotein. This typically is positive only in 40% or so of cases. So therefore, we add it along with the hepatitis B serologies every 6 months. And you'll be surprised that the more you do, you can actually pick up early cancers just based on following the alpha-fetoprotein levels. Okay, but don't do alpha-fetoprotein alone in order to screen for HCC.
Great. Ram, we've got a question from Rihanna that came through in the chat here.
Okay.
It says, for an immune-tolerant patient who does not usually need treatment, if this patient has a family history of HCC at an early age, do you recommend treatment?
Yes. So that is, again, a great question. So immune-tolerant patients, this basically means this is a situation where the patient's ALT is normal and hepatitis B DNA is elevated. So there are different society guidelines, the American, the Asia Pacific, and the European guidelines. And if you look at all these guidelines, there can be subtle differences that if the ALT is twice the upper limit of normal, you need to treat, okay? But as a clinician, we need to identify the risks. The risks are, again, I showed you in the previous module, the one predictor of cirrhosis and HCC is the amount of viral load. If the viral load is more than 5 logs, that patient is at risk to develop cirrhosis and liver cancer. So the general recommendation is you need to identify what are the others. So family history of HCC, clearly this is a risk factor for this patient as well. So this patient, you should actually favor to treat this patient. Other things will be this patient needs to have a fibrosis assessment, maybe even a biopsy, because again, you're trying to make a case. If this patient has more than F2 fibrosis, this is a patient who is again going to have more and more fibrosis during their course, and this patient needs to be treated. Other things, again, is typically we consider age. If the immune tolerant patient is less than 30 and is probably trying to conceive, and the patient is a woman, you can probably wait and have a discussion with her. But typically after the age of 30, again, this is a highly debatable hot topic in all our liver conferences. After 30, we're again favoring, if there is no contraindication, this patient should be treated, even if they're in immune tolerant phase.
Great, thank you, Ram. And just a follow-up question from Rihanna. She just also asked, usually immune tolerant patients are hepatitis B E antigen positive, correct?
They can be E antigen positive or E antigen negative. And immune tolerant phase typically means the patient has normal ALT and the patient has higher viral load. And higher viral load means in E antigen positive patients, it's more than 2,000, basically. But this immune tolerant phase can happen in both E antigen positive and E antigen negative states. Okay. Any more questions? So I wanted to ask our doctor from Nigeria, is he still online?
Abimbola,
Yes.
I'm just going to unmute you.
Dr. Abimbola.
Viral screening is done as part of the pre-employment screening for all professionals, even for those who are not professionals in Nigeria. And once you are identified, you are advised to go for treatment before the employment is considered.
Okay.
So
if the patient, if the individual is susceptible, is hepatitis B vaccination the standard of care?
If it's being susceptible?
Okay.
No, it's not. It's not.
It's not. Okay.
Yes.
Okay. And Dr. Duffy, in New Zealand, you provide vaccination for everyone, all healthcare workers?
Well, New Zealand's slightly different. We vaccinate all children. So for the last 32 years,
okay,
there's been all children have been vaccinated.
Right.
All healthcare workers should be vaccinated.
Right.
Pre-employment. We don't follow up that after a period of time, though.
Got it. Do you see a lot of immigrant population in your practice?
No, New Zealand is, we have, New Zealand has basically, it's bicultural, it's Maori European.
Okay.
There's a high percentage of hepatitis B in Maori population. A lot of that is believed to occur not from mother to child, but in early childhood in Maori transmission. Absolutely. Which is why we were the second country in the world to offer vaccination to all children.
Right, right. Thank you for sharing that information.
We have a question, it appears, from Mubin. So Mubin, I'm just going to unmute you here if you could ask your question.
Actually, this is a template. In fact, I just saw this patient this morning. Okay. Not even morning, it's an hour ago before this project. I don't know. Can I do a
Sure, absolutely. Yeah, we urge you to post these questions.
Okay. So this is a lady who is a 39-year-old Caucasian female, a history of lymphomas, was treated, and then she was diagnosed to also have rheumatoid arthritis. She was on rituximab, and she did have acute, she had viral serology, those were negative, but she had positive antibody, and she had all this typical acute hepatitis B situation. She was on the Viriad for some time, but during the disease process, because her rheumatoid arthritis was getting worse, so she was switched from rituximab to abatacept, I think Arisia, and also interestingly, during that time, she was having hepatitis B antibody that was positive, but for some reason it turned to negative during the course. Right. So we switched her to from Viriad to Wemlidi. Okay. So it was interesting, and I just wanted to know your thoughts about what exactly might have happened that she was mounting immune response on her own. Right. But then she, in a span of 8 months, she turned from Hep B antibody positive to negative. Right. While on treatment all along. Right.
So this is a great case to actually share with the group, because even for me, one of the topics that is close to my heart is reactivation of hepatitis B, especially when the patient is going through a lot of issues like chemotherapy. This could be for lymphoma, this could be for rheumatoid arthritis, this could be for inflammatory bowel disease, you name it. A lot of immunosuppressive agents are being used these days. Okay, the classic one is rituximab. So all chemotherapy, all biologic agents, all monoclonal antibodies can suppress your immunity. And out of them, rituximab is more potent because it is a B cell depleter. Now, when we form hepatitis B surface antibody, all antibodies are formed from the B cells, right? We know that white cells have lymphocytes, and lymphocytes, there is T cells and B cells. T cells provide the cellular immunity. B cells provide the humoral immunity, which is through antibody. So this is one of the important situations where if a patient is getting a B cell depleting agent like rituximab, basically all B cells are going to be gone. So there is no production of hepatitis B surface antibody. So although the patient has been infected, this virus is not going away from the host, right? It remains in the host for the rest of the life. So in a patient with lymphoma on rituximab, this is only expected that at some point, the surface antibody levels are going to wane off and they're going to disappear. That is a perfect opportunity when hepatitis B actually raises from dormancy and causes reactivation. So I too had a typical case where one of our trauma surgeons who actually got infected from one of his surgeries had cleared the virus. He was hepatitis B core antibody and surface antibody, but again, he wasn't given prophylaxis for hepatitis B. He unfortunately got lymphoma, got treated with rituximab, surface antibody levels went down, and he had a flare. We could not save him. No matter what medications you give after a severe flare, he presented with a bilirubin of 20. So there was nothing that we could offer, and transplantation is contraindicated in someone who has extrahepatic malignancy. So we couldn't even transplant him.
So you don't recommend because as you mentioned, if somebody is Hep B core positive and also antibody, they mounted a response, because right. There's one more school of thought that, you can periodically monitor the antibody titers. Right, right. But that's not a reasonable option you suggest.
Well,
right?
The thing is, you have to be watching these titers like a hawk, okay? And remember that the patient's immunity, our own immunity, even in immune competent individuals, there is a lot of physiologic variation. We have different immune levels, even there is a diurnal variation. Our immunity levels are different in the morning and compared to the evening. Okay, so yes, surface antibody titers can be watched, but how frequently can you get the surface antibody titers? How often are you going to check? Every 3 months, every 6 months? There is not clear guidelines to check for surface antibody titers. Whereas the other thing you need to remember is if this patient is really battling through lymphoma, any kind of elevation in liver enzymes is going to basically halt their lymphoma. Okay, so these patients are better off to be on treatment rather than being watched, because when a flare happens, your oncologist is not going to give the patient the chemotherapy, and then the lymphoma can actually take the patient's life.
Thank you. That's good.
Right? Yeah. So in this day and age, like I said, this is a topic close to my heart because of the trauma surgeons and because of several people around me who actually succumbed to reactivation. We do have very effective medications for hepatitis B. So if they are going through other processes in their life that are life-threatening, they shouldn't at least die or succumb to hepatitis B. Okay?
That's
so
fair.
Any high-risk individual should be on hepatitis B prophylaxis. So identify these individuals early on and start treatment.
Thank you.
You're welcome.
All right, Ram, looking at the time, I figured now might be a good moment to see if there's anybody who would like to volunteer to present a patient case during next week's module, which will be sort of a continuation on serology. So at the moment, is there anybody who would like to volunteer to present a patient case to the group?
So just a holler to Mubin, thanks for sharing your case. This is typically how the ECHO project works. Every one of us, we actually see hepatitis B patients. I can basically, if you guys are not willing to share your information, I'm going to share the cases that I see, and we can talk about this, because this is a platform basically to share information and to increase awareness. And we do have fortuitously, we do have providers from different areas in the world. So I think this is a perfect platform to share all that information.
Absolutely. In fact, I have another case, Dr. Berman, but we can talk about it next week in the interest of time.
Okay.
Again, same scenario, multiple sclerosis. They wanted to do some advanced treatment options, and he's a young guy, African American, Hep B core positive.
Yeah. We actually do have some time, so
yeah,
time to actually present it as a vignette. There's no.
Okay, then I'll go ahead. This is a young guy. He's 40-year-old African American male.
Okay.
History of multiple sclerosis. The neurologist wanted to have advanced treatment option. That is, I'm trying to find that case, but they're planning to do an advanced treatment options, which is a kind of a monoclonal antibody treatment.
Right.
So he's Hep B core positive.
Mm-hmm.
I mean, do you have any preference? I mean, I do wanted to put him on a Hep B treatment, but do you have any preference over entecavir versus a newer Vemlidy, or it doesn't matter? You should be on some treatment.
So again, for completeness of the serologies, for monoclonal antibodies, even if you look at adalimumab, which is Humira for IBD, or infliximab, which is Remicade, or even any of the newer monoclonal antibodies for multiple sclerosis, we have to worry about two things. One is what is the intensity of the viral load, or what is the risk of flare because of the virus, and what is the risk of flare from the immunosuppression. So the more intense the immunosuppression is, the higher the risk. And the same way, you also need to evaluate the risk from a viral standpoint. So if the patient only has core antibody, but surface antigen is negative and surface antibody is negative,
yep,
unless the patient gets rituximab, the chance of him reactivating is less. So again, this is based on package insert. Okay, so if you look at any of these monoclonal antibodies, the package insert basically says you need to treat a carrier of hepatitis B, meaning the surface antigen should be positive and they should also have some DNA level. In that scenario, yes, you can use either entecavir or tenofovir. But if the patient only has core antibody positive, although we don't have enough data about whether to start this patient on hepatitis B prophylaxis if the only treatment is monoclonal antibody, I think this patient, you need to figure out, can you vaccinate this patient thinking, is this a false positive hepatitis B core antibody? Right? So rather than subjecting the patient for a whole indefinite period of antiviral therapy, you can probably consider vaccinating, give him 3 shots of hepatitis B vaccine, see if the surface antibody mounts up. Okay. But if the patient has surface antigen, definitely this is a patient who you would like to treat even when getting biologic therapies.
Okay.
Yeah.
Thank you.
Good question.
Thank you.
Perfect. I think we also have a raised hand from Alexander, so you should be unmuted now.
Yes, I'm just taking the post-test, and I disagree with the answer of one of the questions that asked about the best test to order when you suspect of an acute hepatitis B. And if you have only one test to order, I do not think the best option would be to order the anti-HBC IgM, because the marker that it's earliest we can detect is the HBS. So I think if you only have one test to order, you should order HBsAg. It's the one that becomes positive earlier. And the HBC IgM, of course, it's the one that will show that it is an acute infection. But if you do not have the HBsAg, so I think try to reformulate the question, because I do not think the best option, as it was asked, would be the HBC IgM.
Yeah. So I think your point is well taken. You're right. In the setting of acute hepatitis B, and if you only can order one test, that test should be hepatitis B DNA. Okay, it's not even surface antigen, because surface antigen also takes time before you actually see it in the blood. The first sign that hepatitis B is in the host is the presence of replication, is the presence of virus. So really, if you have the option of one test, it should be hepatitis B DNA. So I need Kate. Can you share the question with me, because I think Alexander brings a good point.
Yes.
It shouldn't be the best test. It should be which one of these serologies identifies the presence of acute hepatitis B. DNA can be present in chronic hepatitis B as well, and surface antigen can be present in chronic hepatitis B as well. The only thing that differentiates between acute versus chronic is the presence of IgM core antibody. That is how the question should be formulated.
Yes, thank you. It was good answer.
Yeah.
Absolutely. I'm just trying to load up the question here.
Because HBV DNA wasn't an option, so the only option that showed actually the virus was the HBsAg.
Yes. I think you make a good point, Dr. Alexander.
Yes, so the question does read, the best test for acute HBV infection is. So that's the way it's phrased, is the best.
Okay, so it shouldn't be the best test. It should be which of the following tests differentiates, or which of the following tests is positive in acute versus chronic hepatitis B, and that the answer of core antibody, IgM, will be the answer.
Yes, that will be perfect.
Yes.
Great. We'll make sure that that gets altered. And again, Alexander, thank you so much for pointing this out. This is sort of a part of the back and forth of ECHO that we really appreciate. It helps us improve the program. So that's a great catch, and we'll make sure that that gets addressed.